Good morning. I hope you had a quick coffee and that you are ready for this second live session of ENDOSCOPIC. My name is Jacques Bergman. I'm from the Academic University Medical Centers in Amsterdam, and I will be your moderator during this session. And this session will be all about ZENKER'S diverticulum. And its very structured approach of Stefan and his team is actually reflected in the way we are setting up this session. We will take you through the basics of anatomy and techniques, then exchange some thoughts about pros and cons, and then go to the evidence, and then end up with a discussion also with our virtual faculty in Japan and in the UK. But to set the stage, first we will have Stefan Groth basically explain what a ZENKER'S diverticulum is and what are the key anatomic key points for you to understand during this session. Stefan, good morning.
Good morning. Thank you, Doug. So I'd like to start with my presentation about ZENKER'S diverticulum, and I want to speak about anatomy and the treatment modalities. So in the first picture, please continue the presentation. Yeah, thank you. In my first picture, you see the muscles of the upper esophagus and the hypopharynx. And you can see here the cricopharyngeal muscle. And right about this cricopharyngeal muscle, you see the area, the so-called Killian's triangle. It's an area where we have less muscles or even no muscles. And that is the area where the mucosa herniates through. And as it's right above the cricopharyngeal muscle, the ZENKER diverticulum is actually called a hypopharynx diverticulum and not an esophageal diverticulum. And that might be a bit of a controversy. As we all know, when we examine these patients, we always have to go through a sphincter, then enter the diverticulum, and afterwards go through a sphincter and go into the esophagus. So we don't enter the diverticulum right from the hypopharynx. I want to show you that in a short video. Okay, please start the video. You can see here going backwards from the esophagus, we come to the part of the diverticulum. And here you see the cricopharyngeal muscle, I guess, and slowly pulling backward, it closes again like a sphincter. And I think the reason might be that the upper esophageal sphincter is not just the cricopharyngeal muscle. It's maybe more complex so that it looks like we have a second sphincter here, or maybe it's just a larger one than just the cricopharyngeal muscle. Coming to treatment modalities, we have, of course, surgery with resection and myotomy, or older version, the PEXI with suturing the diverticulum up to the hypopharynx. We have our colleagues from ORL with the rigid endoscopes and with quite the same technique as we do it with an endostapler, CO2 laser, or the coax forceps. And of course, the flexible endoscopy with earlier days APC, then with the coax forceps, now the clutch cutter, and mainly the needle knife myotomy. And very new technique, which we will discuss, is the Z-Boehm's technique. What we know from surgical data is that it's not only the resection of the diverticulum. You have a high recurrence rate if you don't do an extended myotomy and cut the sphincter or the muscles below the diverticulum. And that is exactly what we do with our technique. We cut the septum between the esophagus and the diverticulum, and with cutting the septum, we do the myotomy. And the myotomy is as long as the ZENKER diverticulum is. So it's most of the cases around 2-3 centimeters, and which might be the reason why we are quite effective with the therapy. And here you see below the picture that we open up the septum. The cricopharyngeal muscle is opened up, and we can enter the esophagus quite easily. Also, the diverticulum sac will remain. With the Z-Boehm, we have the same technique, and we have even the opportunity to do the myotomy longer, or as long as we want to, which might be a very good point for especially small diverticulums, as we can't cut a lot of muscle at small diverticulums with the needle knife technique. So, big question for this session is, who should we send these patients? Surgeon, OL, endoscopist, which technique to use, when and why? Jacques, how can we solve this problem?
Thank you, Stefan. I'm not sure if I'm supposed to answer that question, but it's probably best that we start off with basically showing what endoscopists can do.